with the fellows. And so at different pause points throughout the cases, we'll ask for the fellows, oh, very cute, the fellows to comment on whether there's a differential treatment, added questions to the history, and then we'll try to pick on faculty after that to add additional information. And again, we apologize in advance. We're going to try to get to as many people as possible, and if we miss fellows and/or faculty, please don't take it to heart. And again, this is supposed to be a discussion. So once we get to those pause points and after the fellows are engaged, we can leave it open to the faculty to comment on things. And so why don't we get started? I think, is it Sarah? I believe Sarah Frederick, Dr. Frederick is going to be going first. And I have the honor and the pleasure to sort of moderate this section, and then Jen will moderate the second section.
Perfect. Can you guys see my screen?
Perfect.
Okay. So that was a great introduction, and I'm really glad someone showed a picture of Sheltie on the wall, because my live Australian Shepherd is sitting at my feet joining us today. So we may get some input from her as well as everybody else on the call. My name's Sarah. I am the Autoimmune Neurology Fellow at UT Southwestern. Again, to facilitate the discussion that we just talked about, I actually put pause slides in for us, so we know we're kind of reaching a point there together for everyone. So I kept the case short so we have plenty of time for discussion, but I was introduced to this very nice gentleman just a few months ago. So I was seeing a 63-year-old male, and he actually first presented to UT Southwestern in October, but he went to the ENT clinic, and he was coming in with recurrent episodes of sinusitis. So his story that he tells us is he was having recurrent bouts of upper respiratory tract infections that he was intermittently getting treated with antibiotics for, and eventually chose to undergo sinus surgery at an outside hospital in March of this year. After that surgery, though, he began to develop some concerning symptoms, including persistent anosmia. He had unintentional weight loss and fatigue, which was not normal for him because he's actually a health coach instructor. He also lost his appetite, was not wanting to eat very much, and began having headaches. So, of course, as a neurologist, we jump on the headache issue of the above. And he tells me he was really having this constant pressure sensation that was frontally located somewhat retroorbitally on the right side. The headache itself would last for hours into days, but he did not have any associated photophobia, phonophobia, nausea, vomiting. He didn't have any vision changes with this. He had no aura preceding the headache. His headache did not make him necessarily want to go lay down in a dark room, but conversely, he didn't feel like he needed to be getting up, pacing around the room either. He did tell me that it was worsened by sneezing, but then bowel movements and coughing for some reason didn't seem to bother him too much. It did not get worse when he would lay down flat. Initially, he was just treating this with Tylenol intermittently, and it would work, but over time, the Tylenol started to wear off. Now, whilst all these headaches are going on, he continues to have these intermittent, what he's told are upper respiratory tract infections, and he's been receiving steroids and antibiotics for that. And he began to notice that his headaches would get better after he would get those steroids, but as soon as he would taper his steroids off, they would start to come back. When we flesh out his history a little bit more, he actually tells me that just a month before I see him, he went to the emergency room and was admitted to a different outside hospital for what sounds like a generalized tonic-clonic seizure. Now, unfortunately, we don't have a lot of those outside hospital records, so I only have what the patient brought with him. And what we had was a printout that said And he was told that he had a picture of his brain taken, which was an MRI with and without contrast, which revealed a brain abscess. And he recalls being treated with antibiotics for this. He also knows that he had a lumbar puncture there, and we had some of the cell counts. So we saw that he had a lymphocytic pleocytosis with an elevated protein at 73 with normal glucose, no red cells. And the only other thing he's able to really recall about this admission is he was told that he does not have a primary seizure disorder, but instead that this event was provoked by the infection in his brain at the time. But despite that, they still started him on Keppra 1 gram BID at discharge. And when he's following up again a month later, he's tolerating the Keppra well, and he hasn't had any recurrent events concerning for seizure. Since his admission to a separate outside hospital in September of this year, though, he also has a new neurologic complaint, and he says he's been having double vision, which turns out to be a binocular skew. It's equal really in all directions of gaze. He says it's not particularly worse looking in any one direction laterally. He also tells me it's not worse doing things like reading or trying to go downstairs when you need to bring your eyes in adducted and then turn them down. He doesn't have any signs of fatigable muscle weakness on history, and he tells me his double vision's not worse towards the end of the day. The images aren't necessarily getting farther apart. And then importantly, because this is an immunology conference, he doesn't have any pain with his eye movement, and he also tells me that he's not having any vision loss. Apart from that, on review of systems, we don't get a lot of other information. He's actually a pretty healthy guy. He does have hypertension and seasonal allergies, but he's up to date on all of his cancer screenings. From a surgical standpoint, we know he's had his sinus surgery as well as a knee replacement. There's no family history of other neurologic or autoimmune conditions that he's aware of. He doesn't smoke, he drinks socially, there's no drug use, again, works as a fitness instructor, and really hasn't had any recent or remote endemic travel. And then, but he does live in Texas, so of course we think about COVID, and no high-risk social interactions historically. His only medications are losartan, Keppra, and Singulair, and then of course the intermittent steroids or antibiotics that he'll get, and he doesn't have any drug allergies that he's aware of. So on exam, I put together everything here for you but his cranial nerves, and he was actually pretty well appearing. So he wasn't toxic looking, he wasn't cachectic, he looked like his stated age, perhaps a bit fatigued, but his mental status and language exams were without abnormality. His motor exam, he was 5 out of 5 strength throughout. Sensation for both his small and large fiber tracts was intact. His reflexes were appropriate for a 63-year-old gentleman, so 2 throughout with the exception of 1+ at his Achilles. Coordination in the upper and lower extremities was without dysmetria, overshoot, and his gait exam was also completely intact. His cranial nerve exam was probably where the money shot was. So he did have reactive pupils to light bilaterally, but when I was looking at him at primary gaze, his right eye was subtly infraducted and abducted when I kind of looked at that in comparison to position on the left side. When I did confrontational finger counting, he did well, but when we actually pulled out the Snellen chart, his right eye was 2100, but his left eye was 2020. And then in looking at his eye movements, I noticed that he had absent abduction of his right eye. And when he takes his right eye to fully adduct it, he had limited depression. We were all dressed up in our PPE, so it was very difficult to assess his optic discs through our face shields. And then interestingly and importantly, he had symmetric sensation in V1 through V3. And the remainder of his cranial nerve exam was without deficit. So I wanted to take this moment to take a pause and see if people in the audience had clarifying questions about his presentation before we move on to localization and differential.
This could probably be for fellows and faculty alike. And then once we get to the localization, maybe we'll ask the fellows to comment first.
Did he have any worsening of his headache with eye movements?
No, he did not.
Assume that the reaction to light was direct and consensually normal, right? Correct?
Yes.
And Sarah, you had mentioned that with sneezing, it increased the headaches. What about different positions? You may have said it, but I missed it.
Oh, yeah, no problem. So he said that his headache does not worsen when he's supine, nor does it change when he's standing. And he also said it doesn't really bother him when he coughs or with the Valsalva maneuver when he's going to the bathroom.
Just a quick question about his prior infections. Did you mention anything about skin, or was it only sinus infections?
So I didn't mention anything about it, but that's a great question. On further review of systems, he hasn't had any other recurring infections, including dermatologic. They've only been respiratory thus far.
And you don't have any reports as to whether they found anything in his sinuses that was more than the average person has with a little mucosal thickening. So how good is that story of sinusitis always comes up?
Yeah, I completely agree. And that's where certainly we've called the outside hospital a few different times, and we're eager to get those records for questions exactly like that. We know he has sort of quote unquote a baseline MRI compared to now. So we were very interested also in seeing what his sinuses looked like, but also the integrity of his parenchyma.
And no history of any abnormal chest x-ray or renal function problems or hematuria at the other hospital or anything like that.
Correct. There's no history of either of those, although again, he is a generally healthy gentleman. So he had been visiting his PCP once every year to 2 years and would only do kind of the routine screenings at that time, but certainly no emergency visits for complaints like that.
But I mean, when he was in the hospital with a quote brain abscess, one would hope they did at the minimum a chest x-ray, and supposedly there's no abnormalities.
Correct.
Just two more questions. So one is any changes in behavior, and then the second question would be, do you notice any proptosis in his eye, like any edema in the eye area?
Great question. So his skin exam and looking at his eye, no proptosis. The skin was normal in color. Nothing kind of suggesting mass effect pushing out or edema on the exterior. And I'm sorry, what was your first question again?
It was if he's had any behavioral changes.
Yep, and he's no, he's his normal self, and that's according to both himself and his wife who comes with him.
This is
and
Jackie.
I also have a question on oh sorry. I noticed he was on Singular. Does he have a history of allergies, or was that for his sinuses?
So he tells me he has a history of seasonal allergies.
Okay.
This is Jackie. I had a quick question. I may have missed it, but did you mention where the abscess was on his initial admission?
So the report that we got was a text of a physician who had typed in the discharge summary, and all it said was he had an MRI brain with and without contrast that revealed brain abscess. And we unfortunately didn't have further information about the location of it.
Okay, and the CSF testing didn't reveal any other, it was just, like, did they mention any antimicrobial testing or viral testing they may have done? Or?
Right, yeah, no, the only information we had from the CSF testing were ones.
Okay.
So no opening pressure was commented on?
Correct.
Okay.
And a minimal increase in total protein, I think you mentioned, sir.
Exactly. And I interestingly, you guys are asking all the right questions because they're the same ones that my team also had at the same time. And I liked this case because at least I come across this very often, that we get little niblets of information, but not quite the whole picture, particularly for people who are coming to you for a second or a third opinion. So I thought this was an interesting way to present that as well.
This is Teresa from, and can I ask one quick question? Was there any lesions on the roof of the mouth?
No, nothing that I could see inside his oral cavity.
Okay, thanks.
And second, that any genital ulcers that are recurrent?
No, yeah, no recurrent oral or genital ulcers.
Okay. Well, why don't we go to localization? And I'm just going to pick on Daniela because she was asking a specific question about proptosis, and just want to sort of get her thoughts on why she was asking that. And then we'll sort of go through the list of fellows, and then we'll open up to the faculty.
This is Daniela. I was just asking about proptosis or any other signs of mass effect because it seems like he was having some sinus infections, and then there was some diplopia, which could also happen if there were some mass effect behind the eye, but it doesn't sound like that is the case. So far, I feel like the localization could be consistent with optic neuritis due to the fact that he has retroorbital headache. It definitely sounds like he has poor vision in that, I forget which side, I think it's the right eye. And you know, it sounds like if this is optic neuritis, it would be kind of a milder case that he perhaps didn't notice. And then on top of that, there could also be some brainstem involvement because of his diplopia, which sounds like there would be either probably multiple cranial nerves involved, since it is sounds like diagonal, and then it is in all gaze directions.
Okay. How about Sarah Conway? I see you're on the line. Anything to add?
Yeah, I'm here. I think one of the things I'm struggling with is when we hear just that he had a brain abscess or whatever that means. It's pretty non-specific, and for some reason my mind jumped to something in the frontal lobe, like a place that you could hide something and that it would be safe to do an LP. But then when we get the exam, it sounds more concerning for something in the posterior fossa. And the question in my mind is, does he also have a mass lesion there plus a cranial neuropathy? Or is it something more the front part of the brain actually pressing on the globe, causing like a compressive optic neuropathy plus side movement abnormalities? So I think we need more info.
So like a cavernous sinus sort of localization? Is that what you're referring to? Okay. What about John? I'm sorry, I'm going to pronounce probably your last name and butcher it. Ciotti?
Close enough, Ciotti.
Ciotti, okay.
Yeah, I agree with a lot of the things that have been said so far. You know, when I think about the cranial nerves that are involved, you know, my brain is going to cavernous sinus. Multiple cranial neuropathies would also be a possible localization here. But in the context of his recurrent sinusitis, I think about some sort of invasive process in that area, the cavernous sinus, as well as some of the other cranial sinuses, something like IgG4 disease. Sorry, I know we're not at the differential point yet, but.
No, I think it's hard for neurologists, right, to not jump to the differential diagnosis, but definitely you need to think about IgG4 related disorders. And what about Francisco Gomez? I see you're on the line.
Yes, I'm here. Yeah, I don't know that I have much more to add. I do agree with the localization so far. And again, that brain abscess is driving me crazy, just the localization. But I do think somewhere kind of in the cavernous multiple cranial neuropathy. So.
And what do you make of the headaches? You know, just trying to think about a localized region of the central nervous system. I mean, obviously people with cavernous sinus syndrome can get some pretty bad headaches, but often it's localized to that sort of periorbital area versus, if I understood you correct, Sarah, this is more of a diffuse, maybe headache.
Yeah, it definitely starts on his right side, and he says the most amount of pain is right frontal or right retroorbital, but certainly as the headache progresses, it hit really his entire head.
At the beginning, it may sound a little like a Tolosa Hunt type picture. He has the ophthalmoplegia and the headache.
So moving on to the differential, I guess let's, before we go through that,
one question.
Let's ask the faculty.
Are we ignoring the clear-cut difference in acuity? That same eye, which would then have to be, if you believe the optic nerves involved, then you've got to get into the canal, because it's not the tube doesn't come through the cavernous sinus, so you have to be something a little bigger. And my suggestion, we have the same problem that Sarah mentioned. I would ignore the description that he had a quote brain abscess. You have no idea what he had, and it sounds like they may not have either.
And the other thing is, like, it doesn't sound like there was cranial nerve 5 involvement, right? Just if we were thinking cavernous sinus. But
it could be not involving it yet. But if you, even though there was no APD, and you didn't see any pallor. So did anybody do the old central vision with a small red tip match, the old Morris Bender thing that the residents always joke about at Wayne, that I do all the time? Because that'll pick up a very subtle visual problem that would confirm that 2100 was not refractive or something.
That's a really great point. We actually didn't pull that out.
Scott, I want to draw attention to the chat box, and Bridget posted a comment. She says, could be orbital apex if CN2 truly involved, decreased visual acuity, yet no RAPD.
Exactly the point.
Yep, that's a great point. What about, just in interest of time, faculty, anything else to add before we go on to sort of differential? I see Dr. Okai is on. We're just going to start picking on people. I remember when Elliot Froman, he would pick on us. I remember last year, and so we're trying to follow in his footsteps.
Well, you're doing a great job, Scott. But I think most of what the differential and all of that, I don't have much to add to that actually. Yeah, I'm concerned about the multiple cranial nerve palsies and the seizures. So, but the location of the brain lesion, where it is, how it's affecting things, that's an unanswered question, and a piece of information I think will be needed to further advance our thoughts here.
So I'm glad you mentioned the seizures, because I think that, at least in my view, when you have a person with seizure, it's more of a diffuse process, even though obviously we have this multiple cranial neuropathy. So we should keep that in mind as well. Okay, so why don't we go on to the differential diagnosis? I think a couple of the fellows have already thrown out a couple things. One person, I think, said Tolosa-Hunt syndrome, which is a great thought in terms of the cavernous sinus syndromes. Let me see who else is on the line. Not a lot of fellows today. Why don't we circle back?
I think we could add on to, cranial nerve 2 might be a little bit further away, but some kind of basilar meningitis, which could be either inflammatory, especially in the setting seizures, infectious as well, or even malignant.
Yeah.
Multiple different processes still remain in the differential.
So you said a basilar meningitis with multiple cranial neuropathies could also more diffusely get seizures, headaches. Yeah. So Dr. Maida, I think you were going to comment.
Yeah, I was, but that was exactly what I was going to say. What I think Jacqueline just said before me. So I don't really have anything else.
Doesn't sound sick enough to have had a major venous thrombosis, which could give him the seizures, and yet still be coming from the orbital apex and cavernous sinus. They're usually pretty sick if that would be, but that's another way to explain maybe seizures and brain disease in what otherwise sounds to be pretty localized around behind the eye. So that's another possibility. But they usually are very sick looking folks, very sick. And he apparently didn't look really that bad.
That bad, yeah. Yep. How about Sarah Conway? We'll circle back to you. In terms of differential.
One of the things I was thinking about to tie in the sinusitis was like a vasculitis, like granulomatosis with polyangiitis, that actually had a parenchymal component to it.
And they get a perioptic neuritis, not an optic neuritis. So they usually have edema around in the sheath around the nerve, but the nerve is not usually involved. We've had that in a patient who has that exact diagnosis, and it's been reported as a perioptic neuritis, and they can pick off other cranial nerves. You get the sinuses as people are talking. That's why I asked about the lung and the kidney.
I was wondering if Dr. Elliot Froman is on, just to comment on the cranial neuropathies. Obviously, this person had pretty impressive eye movement abnormalities, and I don't know if that helps with the differential in his view, no pun intended. I heard Teresa was on. I don't know if Elliot is. I don't know if he's speaking. Okay. How about Scott Zamvil or any other faculty and fellows in terms of differential?
So
even,
Scott,
go
Scott,
from like the 50,000. Yeah.
It's Andrew Goodman.
Oh, I didn't know you were on. Perfect.
Right. Yeah. So seizures and headache, what always comes to mind is vasculitis when you have that combination. And although neurologists are all prone to want to localize, we have to think that things can be diffuse and multifocal as well, which considering that he has cranial nerves and he had seizures, it seems like it might be a multifocal or diffuse process, like vasculitis.
So like a systemic.
Well, it can be systemic vasculitis or it can be CNS vasculitis too. But I think systemic vasculitis probably.
Hello, this is Daniela.
If the sinuses are involved, then it's systemic, right?
Yeah.
Hello, this is Daniela. So I was just to throw it in the differential, just definitely concerned about optic neuritis. And then in the setting of seizures with, like it was said, some signs of diffuse involvement, like perhaps the diplopia, I would be concerned that his optic neuritis were autoimmune in origin, perhaps with autoimmune encephalitis.
Yeah, no, I think that's a great thought. So
hi, this is Ed Fox. I have one comment I'd want to make on this. If you just take ourselves out of this kind of neuroimmunology mindset and think about is somebody coming into an emergency room who's got a headache, seizures, and multiple cranial nerve involvement, you've got to think about intracranial pressure. An acute increase in intracranial pressure obviously can affect vision, cause seizures, and head pain. So, the sooner you get this patient into a CAT scan, you can find out whether you're calling a neurosurgeon or calling one of us. And I thought taking a step back from that. I know that the timeline of this would suggest it's not an acute intracranial process, but increased intracranial pressure, I think, always has to be in the differential or concern under these circumstances.
I think that's a great point, Ed. I think as neurologists, we do sort of focus in on sometimes the minutia, but depending on the setting, you definitely have to think about intracranial pressure. And I think that's where Sarah was mentioning about, some of the helpful, I think, tips are no change with the headache that the person was experiencing with position. The unfortunate thing is you couldn't look at the optic disc because of the PPE. That's where, getting a call a friend with an ophthalmologist or sometimes OCT is helpful in that setting. But why don't we have Sarah take us through sort of the differential that they were thinking about so we can get to a few additional slides, because now we're at 6:18 and we want to be sensitive with the time. So Sarah, why don't you take it away?
Perfect. Yeah. And so just to kind of let you know where my head was at after I had this information, I was thinking very large, broad strokes, things that we talked about, right? So you have somebody with headaches and seizures, you've got to be thinking, and cranial nerve palsies, you've just got to be thinking about the meninges as an area, right? We talked about the cavernous sinus, especially when you have 3, 4, and 6. It would be more compelling if you had involvement of V1 and V2, but certainly when you hear that triad, your brain should at least consider it. And then because you've got those lower cranial nerves, just thinking about some sort of brainstem process was just large strokes. From a differential perspective, I like to kind of put it in large buckets and then think about individual things that pop into my mind. So of course, the triad for me as an autoimmune fellow is it autoimmune, is it neoplastic, or is it infectious? I visit these 3 categories on almost every consult that I have. Within the infectious spectrum, of course, headaches and seizures, you got to think about meningitis. Now, again, that timeline helps us a little bit. It would more likely be in a fungal or viral category than bacterial, because he didn't look sick and this has been going on for a while. When I start picking off multiple cranial nerves, I always think about TB. And I also always think, especially because I did residency in Virginia, about Lyme disease or neuroborreliosis. Neoplastic lymphoma can look like anything and do almost anything, but especially with multiple cranial nerves involved, something kind of coating the brain or gliomatosis cerebri came to mind for me, especially because remember he had those initial sort of B symptoms, fatigue, anorexia, and weight loss before he came in. Autoimmune, multiple cranial nerves, my mind goes to sarcoid, as well as we already had people mention from a vascular perspective, you've got headaches and seizures, you've got to think about vasculitis and thinking about where you could potentially put a thrombosis that would give you both those headaches and seizures. So what was unique about this case is by the time he was coming to my doorstep, we actually had imaging on him. So I wanted to review the imaging and then we'll kind of revisit that differential again.
Just while you're going through it, Teresa Froman asked about mucor, maybe more mucormycosis, which I think is a great thought, especially if someone's diabetic.
So we're looking at an axial T2 flare image, and you can see I'll come all the way back up in case you kind of want to look at other areas on first pass, but he's really just got this extensive confluent T2 flare signal in his bilateral frontal lobes, which is not entirely unexpected given how he presented. And then we're going to reach the top all the way up here, and I'm actually going to switch us over to the axial T1 post contrast. It's zoomed in a little bit, so I apologize. But you can see as we start to go down in this image, he obviously has some changes status post his sinus surgery, but he's got extensive enhancement and opacification of those ethmoid sinuses, of his sphenoid sinus, his right frontal sinus. But then you notice that that enhancement actually extends onto the dura of his bilateral frontal lobes. And if you look closely and you catch it, you can actually see it's also on the anterior temporal lobes and the bilateral orbital apices. So now that we know we have this on the imaging, and again, I'll kind of put a summary down here. Now this guy has what I call hypertrophic pachymeningitis. So how does that help us adjust our differential? And then what's the workup that we should give the ENT team, because they never did a neurology rotation and they don't know what to do with this.
Similar to before, why don't we have the fellows comment first, whoever's brave enough to take this on, and then we'll ask faculty to add their input. Just when you see people with pachymeningitis, what are some of the common things one should think about that can help determine what you're going to order beyond just the MRI that you have in front of you?
Could be malignancy, could be sarcoidosis, could be an infection like crypto. Yeah, the differential still remains broad.
Any other fellow want to comment?
I think someone earlier mentioned IgG4 related disease, so I think this would definitely make me want to check for that too.
Hi, I'm Jason from Utah. I'm a fellow here in neuroimmunology. I know that we've been talking about vasculitic processes, and one of the things, even if this is not directly a vasculitic process, one of the things that you, I think, have to worry about is now that whatever is invading this area are surrounding the vascular structures, you have to look for possible vasospasms, whatever process is underlying it all, whether it's infectious, neoplastic, or autoimmune.
Sarah, can I ask a question? I assume from the other hospital, we don't know from their ENT people if they biopsied the mucosa when they were in there draining the sinuses. Do we know what they did? Because they may have the tissue and not know what they're looking at.
So he told me he did not undergo a biopsy during that evaluation, but perhaps that's something we would think about for this admission.
I mean, if it were TB, you'd expect a much higher CSF total protein with that much meningeal involvement, I would think. And they usually have very high proteins, TB. You know, yeah.
And, you know, in the past, the great mimicker, right? We talk about, which we don't see, fortunately, syphilis. Yeah, it certainly can cause a pachymeningitis, multiple cranial neuropathies, headaches. So how about Francisco Gomez? What other things should we be thinking about on the sort of systemic side? I think people have commented already, you know, we can't just think about the CNS alone. What are, you know, systemic diseases outside of sarcoid that was mentioned that we should think about?
I believe one of the things that I've seen is, and I do believe Sarah mentioned in her differential, was TB. That can also cause a pachymeningitis. IgG4 has been mentioned.
Teresa Froman had asked about oral ulcers. I then followed up with genital ulcers. Not common in the US, but
Behçet's or neuroBehçet's can do it.
Sarah, could you remind us what's the duration of the illness? Just being treated with some antibiotics that don't have any TB properties. I would think if it's several months, he would not be alive.
Correct. So he, for probably several years, has had intermittent, what he calls upper respiratory tract infections that really picked up probably 6 months before he went in for surgery. And then we're seeing him about 6 months after that sinus surgery. And in that interval 6 months, he had seizures, the skew diplopia developed as well.
Yeah, I mean, if he had antibiotics that don't have any anti-mycobacterial properties, he would not be alive.
We have a comment in the chat from Dr. Okai mentioning that this gentleman had sinus manipulation that then could have created been an extension of the primary or a secondary expansion of infection. And we have another question from Dr. Caban that, do we know his HIV status?
We don't, but we will very shortly.
Mm-hmm. So why don't faculty add to this? What other things should we be thinking about?
So I want to agree with Bob Lisek that I think TB would be highly unlikely because they are incredibly sick if it got this far, and I think just infections in general are less likely given the duration of this and the CSF profile and so on. So in general, although I take your point about spirochetes, but I still favor systemic vasculitis.
Well, one of its named variants, like granulomatosis with angiitis, or he doesn't have any peripheral eosinophilia that we know of, so that one is almost by definition not there, the old Churg-Strauss. But I think, you know, you have all that fatigue, and maybe they were writing that off to recurrent sinusitis. You lose your appetite, things like that. So that some of the systemic clues that Andy was talking about, there may be other explanations, but there may not be. I mean, that may be part of it.
And lastly, it's not an ENT case anymore.
True. Well, let's move on, just because we're coming up at 6:30. I just want to add, you know, Sjogren's syndrome can also cause a pachymeningitis, and if we were in Jamaica, HTLV1 can rarely cause pachymeningitis, and there's a few other things. But go ahead, Sarah. Why don't you tell us the further workup?
Yep. So just real quick, things that I was thinking about, because I just started globally putting it under the umbrella of hypertrophic pachymeningitis. So we covered a lot of these. We talked about the timeline not being quite correct for TB or bacterial, but that's a list of some bacterial infections that are more commonly associated with a hypertrophic pachymeningitis. We talked about syphilis, obviously a fungal infection. Neoplastic, you always want to worry about lymphoma when you see that. And then we touched on the IgG4 related diseases. We talked about sarcoid, but don't forget about overlay syndromes within the autoimmune category as well. Things like rheumatoid arthritis, as well as we've talked about vasculitis a good bit. The other thing is if he had, and probably the most common cause of pachymeningitis that I saw in residency was when it covers the entire brain, you always want to ask the last time that they had a lumbar puncture, because you worry about intracranial hypotension, either spontaneous or post some sort of fluid drainage. Pseudomonas, I think we touched on earlier. And then again, kind of within our backyard, you want to think about the different ANCA vasculitises, Behçet's, Sjogren's, and temporal arteritis.
Yeah, the rheumatoids, they have nodules, so they're not quite as diffuse. But that's a great thought, and they don't have to have known RA, although that's really reportable in that kind of setting. But that's a great point as well. Usually the patients, so you'd have to then give the diffuse meningeal from low pressure as secondary, but he still had all these problems beforehand. And in my experience, I don't know about other people, they have positional changes in their headache. They act like a person who had an LP headache, even if it wasn't from an LP. They don't like to sit up or stand up.
I completely agree. So further workup that we did for him, I divided it out into your serum, what we got when we repeated his LP, and then things that were high yield for infectious disease standpoint. The notable things to see here is that he did have elevated, though non-specific, CRP and ESR. Thinking about vasculitis, at least his C-ANCA came back and was negative. His CBC was not full of eosinophils, which we were worried about. IgG4 was within normal limits. On his lumbar puncture, he did have, 31 nucleated cells. It was a lymphocytic pleocytosis. But we sent for flow cytology and cytometry, which came back negative, although again, we only did one LP, we only did one flow. You should do at least 3 of those to really have a better sensitivity there. And then all of his infectious disease workup came back, as some of the attendings here surmised, negative. He did have this indeterminate quantiferon gold, but we had cultures on him that came back and looked negative. So in thinking about sort of that this could be a systemic process, we also, in the interim, took a look at his CT, chest, abdomen, and pelvis, which didn't show us any evidence of malignancy or other systemic involvement. And the same day that ENT was taking him in to do a dural skull base and turbinate biopsy, I actually got back the results that his P-ANCA was positive. So we sent off his NPO and PR3, both of which came back positive as well. Unfortunately, the results of his final pathology came back and were pretty non-specific. All we got was some fibrous tissue with chronic inflammation, so it wasn't a slam dunk.
So Sarah, how high is that compared to normal, like in your lab, the NPO and PR3? Because there can be some false positives with both of those.
Yep. So I think that the PR3 was on the high end, but not as high as it can get. And then the MPO in our lab, that's like the highest reportable level that they give.
Should also mention that the serum IgG4 being normal doesn't rule in or rule out an IgG4. I mean, that's a biopsy diagnosis. Unfortunately, if you look at the work from Stone and others at Mass General, the serum level doesn't really help you that often.
Yeah, that's a great point.
So ultimately with that information, kind of like I think everything else within autoimmune neurology, it's a bit of a gray area, but ultimately we felt that his case was most consistent with an ANCA-associated vasculitis, keeping in mind his presentations with the fatigue, the weight loss, with his headaches, as well as kind of his more acute presentation with multiple cranial neuropathies. So we treated him as soon as we ruled out infection, we gave him 3 days of IV Solumedrol. He did better from a fatigue, nausea, and headache standpoint. However, his vision got a little bit worse than that right eye, and his diplopia started to worsen. So we actually extended his course out till 5 days and then chose to treat him with an induction dose of Cytoxan. And of course, this is a sensitive topic, whether you choose Cytoxan or rituximab, especially now given the COVID pandemic and with immunizations around the corner. I think that's an interesting point for neurologists currently. We transitioned him to a prednisone taper outpatient, and I saw him just a few weeks ago, and he was actually doing really well. He was pretty much back to his baseline, except for having some very mild intermittent double vision. So just a few points that I had about ANCA-associated vasculitis. So in thinking of, categories of vasculitis, it's small, medium, or large vessels is how people usually group these. So the ANCA-associated vasculitides are going to be more on the order of your small vessel vasculitides. You're mainly going to be dealing with one of 3 different disorders. So granulomatosis with polyangiitis, microscopic polyangiitis, or eosinophilic granulomatosis with polyangiitis. All of these, if they have renal involvement, renal histology isn't going to be particularly helpful. You're going to see that crescentic post-immune glomerulonephritis. But both GPA and MPA are more common in older Caucasian patients, of which this patient was, and generally do present with those constitutional symptoms like fever, malaise, anorexia, and weight loss. They also, like this patient have very common ENT manifestations. Eosinophilic granulomatosis with polyangiitis, on the other hand, you're again going to see those high eosinophil counts peripherally. These people usually are going to have asthma or some other kind of chronic rhinosinusitis. More commonly, these tend to have MPO ANCA positivity versus GPA, which can more often be associated with your PR3, or MPA, which can be associated with your MPO. It's not terribly uncommon to have neurologic dysfunction associated with these categories. And so I liked to bring this case up because depending on where we all choose to practice next year, sometimes vasculitis is seen by the vascular neurologists. Sometimes it's seen by the autoimmune or immunology people. And so at my institution, we take care of a lot of the vasculitis cases because of the immunotherapies that we choose to put these individuals on. CNS involvement happens in about 15% of these individuals. However, most of the morbidity and mortality of these cases is associated with that CNS involvement, which is why it's really important that we sort of talked about and thought about this case today. Involvement's going to happen in really one of 2 large categories. You're either going to have direct infiltration and compression from a granuloma that's been formed, or you're going to have increased permeability of the vessels leading to inflammation and obstruction that way. If you see parenchymal lesions, those are more often associated with some sort of vasculitic inflammation versus if you see extradural lesions, so thinking about the pituitary and thinking about dural lesions, that's probably more closely linked with granulomas. Typically, these people are going to have about half are going to have a relapsing remitting course. And if they do have that CNS involvement, it's going to happen pretty late in their disease. Average onset, in my experience, has been in their 50s to 60s. But again, that classic presentation you want to think about, headaches, seizures, encephalopathy, and strokes. And it can both be hemorrhagic or ischemic stroke. I liked this picture. I learned well from pictures, and I didn't know if other people on the call did as well. But really what you can see here is that the neutrophils have those antigens on the surface, the either PR3 and MPO, and it's a combination of genetic, environmental, and immunologic changes that make those pathologic ANCA antibodies, which when they come out, they activate those neutrophils, which is then further fueled by the alternative complement pathway, so that once these neutrophils are activated, they can actually transverse the vessel wall, and then they undergo degranulation, they have a respiratory burst, they can become necrotic, all of which leads to a complement cascade with endothelial disruption and dysfunction, which leads to eventually inflammation of the vessel wall or vasculitis.
So
The other
Sarah,
thing,
sorry to interrupt. I just want to be sensitive to the time. Would we be able to skip this last slide? People will have this for review. Yeah, and actually you could talk about the treatment real quick so we can get on to the second case. Sorry.
Yeah, no problem. So you have induction and maintenance therapy. When you're doing induction, you want to treat with high dose IV Solu-Medrol and then pick your poison, either Cytoxan or rituximab. I lean towards Cytoxan right now because of not only how severe his presentation was, but also because I'm being mindful of the COVID pandemic with some of the literature that came out about contracting COVID and also how we would expect these people to do if we were to give them the immunizations. Once you get on maintenance therapy, you have one of four main choices: Cellcept, azathioprine, methotrexate, or rituximab. Again, it's really dealer's choice. There is some data to suggest that Cellcept may be less efficacious than azathioprine. I tend to not have good tolerance, or patients don't tolerate azathioprine well when I seem to put them on it. So I lean pretty strongly in the rituximab camp for maintenance dosing. And that's it.
Great. Thank you. I don't know if faculty have any comments about the treatment.
Just one last comment. Bob, are you still on?
I'm here, Andy.
Do you want to mention the seminal work upon which the use of cyclophosphamide is based by Pat Moore and
some guy named
colleague at NIH 40 years ago?
Does that name ring a bell?
Yeah.
Tony started as a vasculitis. I met him when he came and gave grand rounds at Penn. But yeah, he and Pat Moore was a fellow of his after she was with Dale McFarland.
Right.
And they actually did a lot of work on the classification and so forth. And that's with the cyclophosphamide. And then the maintenance, I remember there was an editorial written by my mentor, Bert Swyman, who talked about, the need for comparative studies for maintenance, which we've never really had great ones. I've gotten away with azathioprine, Cellcept. There's never been a head-to-head study. They probably won't be with something this rare. But Andy's right, yeah. But it's interesting that Tony is evolved into ID. He's a clinical immunology by his original training, and so this is, as I said, we've seen some of these ANCA where they're not widespread, but you need to monitor these people either on your own or with help of your internists or nephrologists. Keep an eye on their kidney function and things like that, because they can get that later on. They need not have that first or simultaneously. So they're never really out of the woods. So I constantly, twice a year, get a UA and a BUN and creatinine along with what else I'm following them on.
I would say rheumatologists also get heavily involved because there have been some pivotal trials looking at the impact of Rituxan on some of these granulomatous diseases, and showing it actually is quite efficacious.
Yep.
I'll just make one last comment about the Cytoxan and the setting of COVID. Remember, Cytoxan is a very broad immunosuppressing therapy. And so in the world of vaccinations, we have to be very cautious with having a drug that suppresses many different immune cells, B, T, and other. So I'll leave it at that. But why don't we move
Scott,
on?
Just one quick point. The point is that when you stop Cytoxan, things improve. When you stop rituximab or ocrelizumab or any of the anti-CD20s, the cells come back 6 months, 8 months, 10 months. So the point about is they may be equally safe with COVID around, but they may be an issue for vaccination. And that's a problem in MS. Even if it doesn't make you more severe to be involved, and it does get T cells, as Scott likes to point out as well, the other Scott. But the point is that if they're down, whether you're more liable to get a bad infection than with Cytoxan is one issue. But if you stop Cytoxan, eventually you can immunize. And it depends on whether you think you need your B cells and T cells back normal in the blood for a normal vaccination response in somebody who's on rituximab. And that lasts, I mean, I check usually at every 6 months, and very few patients have got any measurable when I give them their second dose.
So Scott here, very quick question, naive question. I saw the picture with the C5a. Is that an obligate step and downstream of complement activation? And if so, is there any role for eculizumab?
You're asking me or just opening it up to the group?
It's a good question.
Yeah, it's a great question.
Any comment on that? I mean, we think of AQP4 disease where that really is the terminal step and it's highly sensitive to it, but I don't know here there's a lot of other steps. So I'm not sure whether, even though C5a and its activation is how much of a role that has here, but it was in the, so
there
it's
are other
a
things
question.
released that could be toxic as well. I've used a lot of it, a moderate amount of it in ACHR MG, gotten away with it, well tolerated, and anecdotally, I've only had one failure of my myasthenics on eculizumab.
That's a good point.
Good drug.
Good question. Yeah.
Really, really good question. There's a note in the chat box you guys can look at for the names of clinical trials that compared Rituxan versus Cytoxan for ANCA vasculitis. Dr. Pulse Korenberg posted that there, the Raven Rituximab trial. And then maybe it's homework to figure out if any of us by next meeting would consider using eculizumab for vasculitis. That's a really good question. I think for interest of time, we'll move on to Dr. Taga Rempe's presentation. So it looks like he's got his slides set up, and we'll go from there.
All right. Thank you. Can you guys hear me?
Yes.
Okay, very good. So thank you, Sarah. That was a great case. And I will be presenting a case of a 26-year-old Caucasian female with no pertinent medical history who in mid-April of this year started to just notice a very slight left-sided foot drop. She said basically she only noticed it when she was wearing flip-flops, that she had some problems wearing the flip-flops. But then by the end of July, this progressed to now also having trouble moving her left toe, and also with more weakness of her distal left lower extremity, with some associated minor problems with her gait. She denied any other neurological symptoms and denied any history of similar events. She did not travel outside of the country recently. Last travel was like 6 years ago. She denied any toxic habits. She recently moved in back with her parents. She works as a sales manager, and her family history really only was significant for a remote history of a PD and her paternal grandfather, and then prostate cancer at old age of her great grandfather. And with these complaints, she presented first to a general neurology clinic, and on exam, there was basically a very subtle, mild 4+ out of 5 left-sided weakness, evident in her elbow flexion, hip flexion, knee flexion, and foot dorsiflexion, and also some associated left-sided hyperreflexia in her biceps, brachioradialis, triceps, patellar, and Achilles, some unsustained foot clonus with like 4 beats, and pathological reflexes. Both her Hoffman's was positive, and then she had an extensive response in her Babinski. So this prompted an MRI scan, which I've shown here, and I've included the T2 flare, DWI, the susceptibility weighted imaging, and T1 post-GAT. And we'll just go through this. So going down, we do see an emergence of some T2 flare hyperintensities. And then going further down, there are multiple areas of ring-like contrast enhancement with associated susceptibility hypointensities. And going further down, we do see very slight T2 flare hyperintensities tracking down here. So possibly some Wallerian degeneration associated with this. And I've included just an overview slide with the sagittal view of the lesion, and then basically a crosscut with showing the level of the axial sections, depicting these multiple contrast enhancing lesions with these susceptibility hypointensities in there as well. And this basically prompted some ample lab work, including an extensive rheumatological workup, an extensive infectious workup, and what did come back is a very high positive ANA titer. And she also underwent an LP, and the CSF labs were pretty unremarkable. Her oligoclonal bands came back negative, her infectious workup in her CSF came back negative, and also cytology and flow cytometry were unrevealing. And at this point, I want to open up to see, what is your differential for this kind of presentation with this kind of imaging?
Can I ask a quick question? I saw you had a double strand. Is that high for your lab?
Is that?
Yeah, positive anti-double strand. That's elevated for your lab.
That was
yes,
not.
I don't know. It's not elevated.
Okay. Is that what about the pattern of the ANA? Speckled, rim, nucleolar?
That is a very good question, and I asked myself this as well as preparing these slides, but I did not see anywhere actually the pattern documented, including the rheumatology note.
And can I ask people to stop ordering myelin basic protein, much as I like it? It gives absolutely no information. I mean, I wish.
Is that like an ACE level?
It's actually less useful. And it hurts me to say that, because if Whitaker and I and Guy McCann and Sidney Cohn had patented this thing, we'd all be retired. Except John unfortunately died. But I mean, it tells you that there's myelin loss. Whoopee.
Good, excellent point. So coming back to summarize Taga's case, we've got this young woman in her 20s with this imaging, with a pure motor finding on exam of gradual weakness over 2 months in the left leg, no known prior medical problems. Thoughts from the fellows about what our differential is? So we have the two Sarahs, we have Dr. Gomez. Any of you guys, I'll start calling out the other names, but any thoughts on the differential? What would be at the top of your list?
So, I mean, we have a workup that or a serum and a CSF workup that is contradictory to this, but anytime you have ring enhancing lesions, you're thinking about abscess, you're thinking about malignancy. You could be dealing, if it was an open ring enhancement, MS, closed ring, sure it happens, or tumefactive MS. And then everybody loves a good neurocystic I'm not necessarily convinced of any of those in this presentation, but that's sort of my go-to list that I usually think about. The other thing I would say is, I mean, she's young. I don't normally think strongly about malignancy in these folks, but I would retap and I would do flow again.
Okay, all great points. More thoughts?
This is Mila.
Susceptibility.
Oh, hi, Mila. Yeah.
Hi. I lost audio for a minute. Can I jump in with a comment, or are you still fellows?
Well, we'll go ahead and then we'll pimp them some more. Go ahead.
Okay. So I have a question, which is any history of IV drug use, and then I have a comment. I really liked, I think it was Bob's
Listac's comment about stepping back, or maybe it was Andrew about coming into the ER. But what I find really striking about this image is that everything is on one side.
Absolutely.
And when you have this multifocal distribution on one side, I'm thinking, you know, carotid, I'm thinking septic emboli, you know, from potentially a cardiac source. So that's what's striking to me, is this unilateral involvement as we step back and take off our, like, you know, neuroimmunology hat per se. And so then about IV drug use. So the asymmetry of it.
So no IV drug use or any toxic habits in the patient.
I thought somebody said, maybe when Torgay was presenting, that he saw some track stuff on the other side, but I don't see where it would be coming from, because it went by quickly. But Marla's point is, it's very asymmetric if there's anything on the other side. Plus, you have DWI, and so you have both looks like vascular and cytotoxic edema.
I think the other interesting aspect, sorry, this is Jackie, is that there's a lot of vasogenic edema. So if there was more ischemia, I would also suspect more cytotoxic edema, but they are more, I guess, subcortical. But the vasogenic edema and the clustering, like everybody has been saying, kind of makes me think more along the lines of a more indolent, possibly infection that formed abscesses and then led to the vasogenic edema, although a vascular cause is still on the differential as well. And I mean, I guess you could say METs, but the location isn't really correct for that either. But I think the vasogenic edema is also a pretty interesting aspect.
The question of neoplasia brings up a primary B cell or T cell lymphoma. She's kind of young for that, but they can be kind of weird looking like this, and they do enhance in funny patterns. They usually are supposed to somewhere touch the ventricle, and if you look on that sagittal, it does get down against the corpus callosum, and yet they're clearly not dorsal fingers or anything like that. So, yeah.
And there was a question in the chat
Did
about
anybody
cord imaging.
Cervical spine, by the way? Any C-spine?
Yeah, I have not included them, but the spinal cord imaging was normal.
And then Scott, you said we need to look at something in the chat.
Well, that was the question, was about cord imaging. Was that normal? So that was answered. Yeah.
Okay.
All right.
I'll just make one comment. The susceptibility imaging is interesting. I don't know if there's a comment on that, because when we see that pattern, you think about, you know, blood.
Definitely.
Could it also be calcium?
Could be calcium, yeah.
All right. Any other thoughts from fellows or faculty on differential before we move on?
So I'm intrigued by the history of the lone trip to Barcelona, and you know, Spain is famous for its ham and pork products. So somebody already commented on the possibility of cysticercosis. It's just an intriguing historical point there.
6 years earlier, though, I guess it's possible.
You know, can be very
indolent and then spread. Yeah,
very indolent until it's not.
But you and I shouldn't be susceptible to
that. Okay, thanks, Bob. I love the ham in Spain, I'll tell you that.
All right, so let's move on. So basically, when the patient first presented in our neuroimmunology clinic, we did take, you know, a step back and look, asked her again, was there anything kind of preceding this onset of her neurologic deficit? And she actually had an airplane flight on March 15th, and then on March 21st to 24th, did develop loss of smell and loss of taste, also associated fatigue and malaise. She denied any dry cough during that episode, also denied any fever, with a Tmax of 99 when she took her temperature. And this really, you know, pre the onset of the slow emergence of a focal neurological deficit by like a few weeks. So with this history, she did not seek any care during that episode back in March. She did get a PCR, a SARS-CoV-2 PCR in August 2020, which was negative, and then subsequently also had some antibody tests, and in August was negative, and then 2 times in September there were some conflicting results with really a borderline positive result of the Roche test, and then negative results in the diazyme testing. And the second time we also sent it to Abbott, which also was negative. And then later in September, the total antibody stream was completely negative again. And I've included that timeline here. And there was unfortunately no PCR in the CSF performed. And just with this additional information, I wanted to ask again, first of all, what do you think of this episode? Is this consistent with like a COVID-19 syndrome that change our assessment if it does?
So again, we can start with any fellows. So is any of that convincing to you? A young woman returning from college to come quarantine at home. This is all from 2020. Now tells us, well, actually, there was a week where I couldn't smell at all and was highly fatigued about a week after traveling home from college in March. But with some equivocal testing, albeit testing that was done 2 to 3 to 4 months after possibly having the infection. So do we have any thoughts from the fellows and then faculty about whether this influences our decision of what to do next or what the differential is?
Well, I would think that, we don't necessarily know all the neurologic sequelae that's going to come out of COVID. So I don't think you can definitively say, no, it's not related. I don't know that I've seen a progressive case where the patient continued to get worse. I think I've seen a few cases of like ADEM and like transverse myelitis, but not something that's been getting worse over time.
Yeah, AHLE has been also reported from our colleagues over at Henry Ford, but this is very slow for that kind of thing. And I think your point is well taken. I think if you try to decide what are the neurologic complications or associations with COVID, every time you could write a new review once a month because they keep being added.
All right. Any other thoughts or any other reflections on the differential before Dr. Rempe moves on and gives us some more, perhaps defining information?
Perhaps I missed this, but did we do cardiac testing before? Because I mean, maybe with the COVID, you could link it not directly to a neurological thing, but like something with a heart issue, and then maybe a superinfection. I don't know, but that's the only thing I can think of that would add to that.
Well, she's got a positive ANA, so you might want to see if she doesn't sound like she meets any criteria for lupus except the ANA.
Mm-hmm.
But you could argue Goldman Sachs if you have sensitive echo, because they can embolize, and that would give you asymmetry, but that's a real stretch.
Great. Any other thoughts, fellows or faculty?
Was there any SED rate or CRP testing? I may have missed that.
Yeah, those were normal.
Okay, I was just curious because sometimes I think ANA can be falsely elevated in the setting of infection as well. I'm not sure.
It goes up with everything. I agree.
Yeah.
That's why I asked about the pattern. They're often speckled when they're non-specific.
I'll just make a comment. I may have missed this, but APLS, antiphospholipid syndrome, you can get a whole host of weird things, including, both venous thrombosis, ischemic strokes. There's a lot that can happen with that. So did you guys check for lupus anticoagulant?
And it was negative.
Okay, sorry, I missed that.
All right, so moving on. So we did ask our infectious disease colleagues what they thought about this episode, and they were pretty convinced actually that this, was consistent with a mild COVID-19 infection, and they mentioned that this antibody testing really in mild cases after 3 months they do see often those antibodies returning negative, and just with our differential, including neoplasm, including infectious causes. Someone mentioned, repeating an LP for flow cytometry, but really, they weren't really a lot of cells in the CSF. So we really wanted to, understand quickly what was going on here. So we did decide to get tissue from that lesion. And this is the brain biopsy of that right frontal lesion. And what we can see is pretty extensive perivascular lymphoplasmacytic inflammation with basically also like lymphocytic infiltration of the vessel wall with resulting endothelial hypertrophy. And looking at the immune histochemistry, those cells were predominantly CD3 positive T cells, and then a small subset of CD20 positive cells. And then the pathologist also commented on areas of eosinophilic coagulative necrosis and also presumably dystrophic calcification. So they did check, for signs of infection. They didn't find any microglial nodules, no neurophagia. They sent tissue for cultures, which basically came back negative. They did Gram and AFB stains and GMS and PAS stains and did not identify any kind of organism in there. We did ask them for in situ hybridization for SARS-CoV-2, but they basically did not have the ability to do that, and reached out to the CDC. It seems like the CDC currently is only accepting autopsy tissue, so they were unable to complete this. And basically, their final neuropathologic diagnosis is the diagnosis of lymphocytic vasculitis. And with this additional information from the biopsy, now what do you make of this? And then of course, in this young woman, what kind of treatment would you propose next steps in managing this disorder?
And maybe before we leave the path slides behind, I'm wondering if any of the faculty want to make any comments. Dr. Okai, Dr. Mowry, Dr. Goldman, Dr. Lissack, Dr. Goodman, and Dr. Froman, anybody want to make any comments about the pathology?
I have a question, though. I assume that they stained for in order to tell proliferative index, and this was not increased.
They did not mention it in their report.
I mean, it doesn't look like a lymphoma, but I mean.
Yeah. Oh yeah. So
you can measure, 67 or things like that, looking for proliferative index. I mean, it does look like a vasculitis, and it is not pure T or pure B, mainly T. So. And again, we've now probably added one more thing that COVID-19 can do.
Any other thoughts on the pathology from fellows, faculty? I think I named almost all, well, not quite all the faculty. Dr. Zamble wants to, anybody else have any comments before we move on to how the patient was managed? Okay, go ahead, Dr.
I didn't have a.
Oh,
I have a
go
quick
ahead,
question. Not about. I don't have a comment about the pathology, but with this pathology information in hand, did you go back and do vascular imaging or cerebral angiogram, and did it drive you to do additional assessment?
Yeah. So we did discuss that actually in depth with rheumatology, with neurosurgery, and we thought at this, it is an invasive procedure, and we weren't sure if this would really yield additional information. And then we discussed it with the patient as well, and she decided not to go for a DSA.
These are pretty small vessels, right?
Yeah, I was gonna say very tiny.
I mean, usually you do the angio and don't get an answer, or you get a questionable lesions, and then you do the biopsy. So you've already got the biopsy. I don't think you're going to find large enough vessels to help you.
But is anybody else intrigued by the calcification? And did she have a CT scan just to look at the calcium? Sometimes there are patterns of calcification that are recognizable to neuroradiologists.
I think she did have a CT scan, and actually nothing popped out there.
It does raise the issue that when Scott Newsom was mentioning about that susceptibility weighting image, doesn't it?
Yeah. It's really interesting. Really interesting thought there. I believe she did have CTAs done up front. Could go back and look at those, Dr. Rempe, and see if there was anything there missed by radiologists, but I don't remember anything. All right.
I would say I don't blame you guys for going right to the brain biopsy, because I think we're often hesitant to go right where the money's at, and we end up doing excessive workup, including repeat taps and cerebral angiograms, which, if you look at the data, most of that is not really helpful, at least for some conditions. And so, to Bob Lissak's point, you're looking at an area of the brain where it's very small vessels. And so I applaud you guys for pushing forward to get a brain biopsy.
Sutton's Law. Why do you rob banks, Willie? That's where the money is.
That's right.
But sometimes the neurosurgeon is too timid to get the relevant tissue.
That's a case report, a timid neurosurgeon.
I have to agree. This is Ellen. And I've even had patients who've had positive flow on multiple taps and out of the vitreous with the same pattern. And oncology sometimes is unwilling to even proceed. For example, in this case with lymphoma, I'm thinking of without a biopsy. So I've really pushed more towards early biopsy rather than waiting a week and a half for more disease to develop in more aggressive cases than what you're describing here.
Okay, Dr. Rempe, you can take us through the remainder of your slides.
All right. So basically, treatment-wise, the treatment with Cytoxan, came up, and we did discuss it with the patient, and in the end, we were thinking, well, she's very young, and the possible effects of Cytoxan could have a huge impact on her, and her deficit is very mild. So we decided to go more conservatively with a pulse of IV steroids, followed by a very slow prednisone taper starting at 60 milligrams, and then initiation of CellCept. And following the IV solumetric pulse and follow-up in clinic, she did not notice any direct effects after the infusion, but a few days after, she noticed improvement of her left lower extremity strength, and also her parents have noticed improvement of her gait. And that's something we could also see objectively with improvement of her distal left lower extremity weakness, and following her over time, she does notice slight continued clinical improvement to date under that regimen. Following that clinic visit, we did get a repeat MRI as well, and those are the same, the same T2 flare, DWI, susceptibility weighted imaging, and T1 plus GAD. And I've put side by side the initial MRI and this repeat MRI after about 6 weeks, and we can see that it's still present, but there's an improvement of the T2 flare hyperintensities, and also, while still faintly present, an improvement in contrast enhancement. So, looking through literature, there are 3 case reports of suspected COVID-19 associated vasculitis. One by Vascato, one by Dixon, one by Hanafi. And looking at those, all of those were, suspected vasculitis based on imaging finding, with scattered ischemic lesions. One did have some susceptibility weighted abnormalities here as well, but none of those were biopsy confirmed. And they said some major differences to our case. So first of all, those were all older patients with comorbidities and had a very significantly worse COVID-19 infection. So all of them required ICU care, and 2 of them were intubated for that infection. And it seems like also that those neurologic deficits did emerge faster in these patients, not this very prolonged, slow progressive course like in our case. And looking at possible underlying mechanisms, so there is evidence that SARS-CoV-2 is infecting endothelial cells, and that has been shown here in the kidney, in the gut, and also in the lung. But it has also been shown in the brain, and the question is, is this resulting in some kind of endothelitis from this endothelial infection? And that's what I have.
Excellent. Thanks, Taga. Any final thoughts, comments? One question that comes up is, the biopsy could be interpreted as primary CNS vasculitis unrelated to COVID, or it could be a COVID-related vasculitis. So duration of treatment is an interesting question in this case. If we think that was triggered by an infection, has the infection triggered a more prolonged process, or is this a para-infectious complication? So really interested in all of your thoughts on the possible immunology for this case and the implications for this young 26-year-old woman and how long she needs to be immunosuppressed.
Be nice if they had looked, were able to look with PCR or something, because there are more and more vasculitides that are idiopathic, or not idiopathic eventually. The late Don Gilden was doing some interesting work on quote temporal arteritis, finding VZV, so if you knew there was no virus active in there, if that's how it caused the vasculitis to start with, then I think you would immunosuppress her for a while, and then, like Pat Moore and Fauci used to do, is gradually down. They used to do in the old days serial angiograms if the first angiogram was positive, because serial biopsies, it's multifocal anyway, it might not help you even if it was safe. So I think it would be nice if we knew that there was no active infection in there, but I think from what you can see, I would treat it like a primary CNS vasculitis, a quote idiopathic. Again, as we said, somebody once pointed out that if you didn't have dark field microscopy, lupus would be syphilis. I mean, because you can see the spirochetes in syphilis, but when you get these multivasculitic, multi-inflammatory, all over multiple organs, as we get better at identifying infectious, there is a virus that affects turkeys of all things that gives what looks like primary CNS vasculitis, except that they can find the virus in the turkeys. So we don't know yet what all these vasculitides are, I don't think.
I agree. Has anybody reported actually finding virus in brain tissue? There's been lots of autopsies.
So it's Scott here. Can I just speak up for a quick second? There's been no evidence, as far as I know, of SARS-CoV-2 in parenchyma.
Yeah, that's what I'm saying.
It's been in endothelium and cord plexus. So exactly what Jen was saying. Is this associated or independent of having had this case of COVID without in situ hybridization to show that there's some virus there? It's kind of stuck at that point.
And if you didn't show it now, considering how long ago the infection probably occurred, it would be, I'd feel safer suppressing her, but it wouldn't prove that it didn't start that way with the ACE2 receptor on the endothelium.
True.
All right, we have come to the end of the session, but any other last comments, questions? I think both presentations were fantastic. They weren't planned to be a theme of vasculitis, but it worked out nicely to two different stories of vasculitis. Any other final comments, questions from fellows or faculty? Otherwise, I'll just say congratulations to the fellows. Excellent presentations, excellent discussion here in the chat box. Also, Sarah has posted a few links have been posted here, and Ellen Mowry says Carlos Pardo says it's not in the brain. Also says it's not in the brain. Any other final comments?
I have one last question, if that's okay. And
Yes.
I agree, these were really great presentations, and I enjoyed them both. So you mentioned treating her with methotrexate. I mean, although we're talking about vasculitis in general, but would an intravascular lymphoma still be on the differential? Because I mean, could that be considered partial treatment with the methotrexate too? And how would you go about continuing to monitor that? And what might you expect if that's the case?
So we did treat with a CellCept.
CellCept,
not with methotrexate. Okay. I think that's an option. But monitoring wise right now, I mean, we're really clinically she's improving. So we have an MRI scan lined up actually in the end of December to reevaluate how she's developing from a radiological standpoint. But as long as she's improving clinically and radiologically, but I think that's how we would continue to monitor her.
That's why I just again asked about proliferation index, because in a vasculitis it would be mildly elevated. In a lymphoma, you would expect it to be pretty high, and you could probably also demonstrate if it was a B-cell lymphoma, which it doesn't seem to be with the CD20 staining. So primary T-cell intravascular lymphoma would be really rare, and it doesn't look like there's that much proliferation. But that's why they usually do look for proliferative indices when they do biopsies, and you see a lot of lymphocytes.
Yeah, wonderful. I just want to make one last comment, then maybe we should cut it because we're a few minutes over. So I just want to thank all the faculty that stayed on with us and that really had a robust engagement. And please send us feedback, fellows and faculty, if you enjoy the way we're doing things. And there's always ways to improve upon how we're doing these webinars. So please be candid with your feedback, and we'll take it all into consideration. So
if people have some of these references, if they send them to Doris, perhaps Doris could then send them with with an email in the next few days. That would be nice. As something, it's always easy to ask somebody else to do extra work in case of Doris. I know she likes to do it.
Yes,
so.
please. Whatever you guys send me as references, I will add on when I post the recording. I add it as links below. So whatever you want me to post, send it over to me. Thank you.
All right.
That's great.
Thanks,
All right, everybody.
Stay
so
safe.
much.
See you in 2021.
Yes, 2021.
Take care.